Hello friends, today we are going to discuss the Clostridium difficile infection. The question which was asked in DRNB Critical Care Exam June 2022. So the question was causes of diarrhea in critically ill patient and diagnosis and management of Clostridium difficile. So causes of diarrhea in critically ill patient, common is the CMV infection, Clostridium difficile infection, small bowel bacterial growth that is E. coli, Campylobacter, Shigella, Salmonella, MMF drug therapy. Unusual causes are infection other than the CMV and bacterial, that is adenovirus, astrovirus, human herpes virus, norovirus, dengue fever, candida, parasites like blastocystitis, then Hymenopsis nana, then this Trichuria stichuria, Isospora bailey, and Entamoeba histolytica. Non-infectious colitis and the drugs other than the MMR. There are graft versus host disease, post-transplant liver disease, microscopic colitis, and colon cancer. Now, how to diagnose the Clostridium? Now, regarding Clostridium difficile infection, how to diagnose this? Patient with the unexplained and the new onset, more than 3 unformed stool in 24 hours. A preferred target population for testing for Clostridium difficile infection. Use stool toxin test as a part of multi-step algorithm. That is glutamate dehydrogenase plus toxin, and arbitrate by nucleic acid amplification test and nucleic acid amplification test plus toxin rather than nucleic acid amplification test alone for all specimens received in the clinical lab. Use of the nucleic acid amplification test alone or multi-step algorithm for testing rather than toxin test alone when there are pre-agreement institutional criteria for patient stool submission. So this is the algorithm, that is clinician and the lab person agree at the institution level to not to submit stool specimen on patient who are on the laxatives and to submit stool specimen only from patient with unexplained or the new onset three unformed stool in last 24 hours for testing Clostridium difficile infection. If this is the situation, then the go for nucleic acid amplification test alone or stool toxin test as a part of multi-step algorithm. That is, as I mentioned before, that is GDH plus toxin arbitrated by nucleic acid amplification test or nucleic acid amplification test or alone. And if it is not a case, then go for stool toxin test as a part of multi-step algorithm. That is GDH plus toxin arbitrated by the nucleic acid amplification test or nucleic acid amplification test rather than nucleic acid amplification test alone. Then do not perform repeat testing within 7 days during the same episode of diarrhea and do not test stool from asymptomatic patient except for the epidemiological studies. Now, how to treat this? Discontinue therapy with the inciting antibiotic agent as soon as possible, as this may influence the risk of Clostridium difficile recurrence. This is a strongly recommended. Antibiotic therapy for Clostridium difficile infection should be started empirically for situation where substantial delay in lab confirmation is expected or for fulminant Clostridium difficile infection. We can start with either vancomycin and fidaxomicin over metronidazole for initial episode of the Clostridium difficile infection. If we are planning to start vancomycin, we can start vancomycin in the dosage of 125 mg orally 4 times a day or fidaxomicin 200 mg twice daily for 10 days. In setting where access to vancomycin and fidaxomicin is limited, we suggest using metronidazole for initial episode of non-severe Clostridium difficile infection. The suggested dose of metronidazole is 500 mg orally 3 times a day for 10 days. Avoid repeated or prolonged courses due to risk of cumulative or potentially irreversible neurotoxicity. Then regarding fulminant Clostridium difficile infection. Pulmonary Clostridium difficile infection, previously referred as severe complicated by a complicated Clostridium difficile infection, which may be characterized by hypotension or shock, ileus, or megacolon. So, in this case, vancomycin should be administered orally, is the regimen of choice. If ileus is present, then vancomycin can be administered per rectum. Then the vancomycin dosage is 500 mg orally 4 times per day and 500 mg in approximately 100 ml saline per rectum every 6 hours as a retention enema. Intravenously administered metronidazole should be administered together with oral or rectal vancomycin, particularly if ileus is present. The dose of metronidazole is 500 mg intravenously every 8 hours. If surgical management is necessary for severely ill patient, perform subtotal colectomy with preservation of the rectum. Diverting loop ileostomy with colonic lavage followed by antegrade vancomycin flushes is an alternative approach that may lead to improved outcome. Then regarding recurrent Clostridium difficile infection. Treat first recurrence of Clostridium difficile infection with oral vancomycin as tapered and pulse regimen rather than second standard 10-day course of vancomycin. Treat first recurrence of Clostridium difficile infection with the 10-day course of fidaxomicin rather than 10-day course of vancomycin. Then treat first recurrence of Clostridium difficile infection with standard 10-day course of vancomycin rather than second course of metronidazole if metronidazole was used for primary episode. Then antibiotic treatment option for patient with more than one recurrence of Clostridium difficile include oral vancomycin therapy using tapered or pulse regimen, then standard course of oral vancomycin followed by rifaximin and fidaxomicin. Then we can also go for fecal microbiota transplantation for patients with multiple recurrence of Clostridium difficile infection who have failed appropriate antibiotic treatment. Now, these are the recommendations for treatment of C. diff infection in the adult. If so, it is basically divided into the initial episode, which is non-severe, severe infection, then fulminant infection, first recurrence, and the second subsequent recurrence. So, if initial episode is non-severe, that is, if leukocytosis with white blood cell count of less than 15,000 and the serum creatinine level of less than 1.5, then we can treat this infection with the vancomycin 125 mg given 4 times daily for 10 days, or we can treat with the fidaxomicin 200 mg twice daily for 10 days. Alternate if above agents are available. If vancomycin and fidaxomicin both are not available, then go for metronidazole, that is 500 mg 3 times daily by mouth for 10 days. If initial episode is severe means if WBC counts are high, that is more than or equal to 15,000, and along with that, if signs of dehydration is present, like creat is high, that is more than 1.5, then treat this infection with the vancomycin 125 mg 4 times per day by mouth for 10 days, or fidaxomicin 200 mg twice daily for 10 days. If initial episode is fulminant, that is, if the patient is in hypotension or in shock, if ileus is present, if megacolon is present, then in that case, we can use the higher dose of vancomycin, that is 500 mg 4 times per day by mouth or by nasogastric tube. If ileus is there, then consider adding rectal installation of vancomycin. Intravenously administered metronidazole, that is 500 mg every 8 hours, should be administered together with oral or rectal vancomycin, particularly if ileus is there. If there is first recurrence, then we can add vancomycin 125 mg 4 times daily for 10 days if metronidazole is used for the initial episode. Or we can go for the pulse or tapered vancomycin regimen if standard regimen was used for initial episode. Now, what is this pulse or tapered mid regimen? So we can use the dose of vancomycin in the form of 125 mg 4 times a day for 10 to 14 days, 2 times per day for a week, once a day for a week, and then every 2 to 3 days for 2 to 8 weeks. Or we can also go for fidaxomicin, that is 200 mg twice a daily for 10 days if vancomycin was used for the initial episode. Then if for the second recurrence or subsequent recurrence, also we can use vancomycin in tapered dose or vancomycin in the dose of 125 mg 4 times a day for by mouth for 10 days, followed by rifaximin 400 mg 3 times daily for 20 days. Or we can use fidaxomicin, that is 200 mg twice a daily for 10 days. Or we can go for fecal microbiota transplantation. Now, the most important part is prevention. How to prevent this? So, whenever you will find the Clostridium difficile infected patient, accommodate that patient in the private room with dedicated toilet to decrease the transmission to the other patient. If there is a limited number of the private single room, then prioritize patient with the stool incontinence for placement in the private rooms. If cohorting is required, it is recommended to cohort patients infected or colonized with same organism. That is, do not cohort patient with Clostridium difficile with who are discordant for other multi-drug resistant organism like methicillin resistant Staphylococcus aureus or vancomycin resistant enterococcus. Healthcare personnel should wear gloves, gowns on entry to the room with Clostridium difficile patient or while caring for patient with the CD. Patient with the suspected Clostridium difficile should be placed on preemptive contact precaution pending Clostridium difficile test result if test result cannot be obtained on same day. Continue contact precaution for at least 48 hours after diarrhea has resolved. Prolong contact precaution until discharge if Clostridium difficile infection rate remain high despite implementation of standard infection control measure against Clostridium difficile infection. In routine or endemic setting, perform hand hygiene before and after contact of patient with Clostridium difficile infection and after removing gloves with either soap and water or alcohol-based hand hygiene product. In Clostridium difficile outbreaks or hyperendemic setting, perform hand hygiene with soap and water, preferentially instead of alcohol-based hand hygiene product before and after caring of patient with Clostridium difficile infection, given the increased efficacy of spore removal with soap and water. Hand washing with the soap and water is preferred if there is direct contact with feces or an area where fecal contamination is likely. Encourage patient to wash hand and shower to reduce the burden of spores on the skin. Use disposable patient equipment whenever possible and ensure that reusable equipment is thoroughly clean and disinfected, preferentially with the sporicidal disinfectant that is equipment compatible. Terminal room cleaning with the sporicidal agent should be considered in conjunction with other measures to prevent Clostridium difficile infection during endemic high rates or outbreaks, or if there is evidence of repeated cases of Clostridium difficile infection in the same. Incorporate measures of cleaning effectiveness to ensure quality of environmental cleaning. There are limited data at this time to recommended use of automated terminal disinfection using sporicidal method of Clostridium difficile infection prevention. Daily cleaning with the sporicidal agent should be considered in conjunction with other measures to prevent Clostridium difficile infection during outbreaks or in hyperendemic setting, or if there is evidence of repeated cases of Clostridium difficile infection in the same. There are insufficient data to recommended screening for asymptomatic carriage and placing asymptomatic carrier on contact precaution. Minimize the frequency and duration of high-risk antibiotic therapy and the number of antibiotic agent prescribed to reduce the Clostridium difficile infection. Then implement antibiotic stewardship program. Antibiotic be targeted should be based on the local epidemiology and Clostridium difficile strain. Restriction of fluoroquinolone, clindamycin, and cephalosporin should be considered. Although there is epidemiological association between PPI use and C. diff, unnecessarily PPI should be discontinued, but there is insufficient evidence for discontinuation of PPI as a measure of preventing C. diff. There are insufficient data at this point to recommended administration of the probiotic for primary prevention of the C. diff outside the clinical trials. So this is the trial which was published in NEJM in 2017. According to this trial, the basilotoxumab was recommended for the prevention of recurrent Clostridium difficile infection. And also the another trial which was published in the NEJM. According to this trial, the ACR 109, the oral microbiota therapy, was useful for the prevention in the case of recurrence of Clostridium difficile infection. Thank you, guys.